So I'm going to talk to you this evening about growth hormone, and I'm going to talk about what happens if we have too much or too little. Okay, so just to show you, I just might get rid of that for a second, sorry. So just to show you what I'm going to talk about over the course of the next 30 minutes or so, I'm going to have a bit of a refresher just for a couple of slides about growth hormone, where it comes from and what does it do. Then we're going to talk about what happens to the body when there's too much growth hormone. And then we're going to talk finally about what are the consequences if growth hormone production is low, so too little. Okay, so let's start from the very beginning. Where does growth hormone come from and what does it do? Okay, so this is a picture of the pituitary gland. So just to orientate you, okay, this is the front and this is the back. So it's as if I've taken a slice down the middle of the brain between the eyes. Okay, so you might, and some of the words I'm putting it out here are really just because you might have read these letters in clinic letters and sorry, these terms in clinic letters, and it might just be about sort of explaining what it's all about. But I know that many of you will have done some reading over the years about pituitaries anyway. But here is the front part of the pituitary, and we call that the anterior pituitary. And this is the back part of the pituitary. We call that the posterior pituitary. And as you can see, the pituitary gland hangs from a stalk. This is the stalk here. And that's sometimes called the infundibulum, as I've put at the top there. So a back and a front part. And they make different hormones. The anterior and the posterior pituitary hormones pituitary glands make different hormones, but they're sort of seen together on an MRI scan as one whole gland. And growth hormone is released from the anterior pituitary, so that front part of the pituitary gland, from some special cells called somatotrophs. Okay, so I know because I'm talking to patients with all different pituitary conditions, I thought we might just spend a second talking about the different types of pituitary hormone that there are, and generally speaking, what they do. So when I'm teaching medical students, I always talk to them about the rule of five, because I find that's an easier way to keep it in my head anyway, that there are 5 different types of anterior pituitary cell, and they're making different hormones depending on that cell type. So from the top, because that's what we're going to be starting to talk about this afternoon or this evening, we've got growth hormone, and that acts on various body tissues, particularly the liver, and I'll come on to describe that in a sec when we talk about growth hormone in more detail. We've got prolactin. Some of you may have had a pituitary tumor, and I use the word tumor not as a cancer, but a collection of cells that are a bit busy and making a bit too much hormone often. So you might have had a prolactinoma making too much of the hormone prolactin, and that's important for lactation in women post-pregnancy, so in order to breastfeed their babies. There's a special type of hormone made from thyrotrophs, special cells in the thyroid, in the anterior pituitary gland, called thyroid stimulating hormone, or TSH, and TSH tells the thyroid gland in the neck to work. We've got a special cell type which makes gonadotrophins, that signals from the anterior pituitary to the testes in men or to the ovaries in women, telling the testes to make sperm and testosterone in men, and in women, the ovaries to make estrogen and release an egg. And those hormones are LH and FSH. They're called the gonadotrophins. And then finally, the 5th one on my list is the longest name. It's a real long name, adrenocorticotrophic hormone, which you might have seen abbreviated on your clinic letters to ACTH, which tells the adrenal cortex to make cortisol. Some of you may be on replacement for cortisol, such as prednisolone or hydrocortisone. So the way I always think about the anterior pituitary gland, and I'm sorry, I don't know that I can get rid of this bar at the top, sorry. But the way I always think about the anterior pituitary particularly is it's like a telephone switchboard. It's such a clever gland. It's only the size of my thumbnail, but it's sending out all these messages all over the body to make different body systems work. Okay, so how does growth hormone work? Because that's what we're going to focus on this evening. So why don't we start at the top here with the anterior pituitary, so the front of the pituitary gland with those 5 different cell types, and we know that some of those cells are somatotrophs, they're making growth hormone. So growth hormone is carried in the bloodstream because that's what a hormone does. It's carried in the bloodstream from one place to another, where it's made to where it takes effect. So growth hormone is carried in the bloodstream and it comes along to its sort of target tissues, which are, this is muscle, bone, the lung. It can make various things grow usually, and it does that by binding to a growth hormone receptor on all these different tissues. Growth hormone receptors are very prevalent in the body. Now, growth hormone also has what's called metabolic actions, and I'm going to come on to that a bit later on. For example, it can have effects on protein formation, which is good in terms of trying to make things grow, might have effects on blood glucose and increased blood glucose or sugar, which if we've got too much growth hormone can be a little bit tricky. So it has other effects, not just making things grow, and we call those metabolic effects. But generally speaking, the role of growth hormone is to make things grow, particularly important as we transition from child to young adult to adult. So our growth will be dependent on other hormones too, like sex hormones, but very, very important for growth, for us to have growth hormone to grow from a child to an adult and to develop. Now, I thought it was important to also mention this other hormone because, again, we're going to talk about IGF-1 in a minute. And again, you might have seen this on your clinic letters over the years. So I wanted to just explain what that was. So growth hormone, as I say, is released from the anterior pituitary, so the front of the pituitary gland, and it acts on various receptors around the body and makes things grow, in essence. Okay, but what it also does is it goes to the liver and it tells the liver to make another hormone, which we call insulin-like growth factor, abbreviated to IGF-1. And IGF-1 can also be carried in the bloodstream, work on similar tissues such as muscle, such as bone, bind to its own receptors, the IGF-1 receptors, and also cause growth. It can also cause those metabolic effects that I've talked about too. And again, this will cause growth and development. So growth hormone is very clever because it's able to make growth happen directly by binding to growth hormone receptors. And it's also able to make growth happen indirectly by telling the liver to make a second hormone called IGF-1, which then also causes growth. So very clever system, the growth hormone system. And as I say, some of you will have learnt about IGF-1 when you read your clinic letters, and we're going to talk about it a little bit later on when we talk about too much growth hormone. Okay, so the other thing to say is that growth hormone secretion is up and down, and sometimes we call that pulsatile or spiky. So you can see here it's going up and down, up and down, up and down. And what you can learn from this graph, so this is 8 o'clock in the morning, this is 8 p.m. and this is 8 o'clock the following day, so 24 hours. And here we have growth hormone. So you have a little flurry of growth hormone spikes as we're getting up. And that's quite common for lots of hormone systems actually to do with the anterior pituitary. So we also see that for ACTH and cortisol, for example. It's a hormone that helps get us out of bed in the morning if our pituitary is working normally. But what you'll also see is that there's lots of growth hormone secretion at night. In fact, most of us are making our growth hormone at night. And that's particularly true, for example, with children. So going through puberty, you get lots and lots of growth hormone pulsatility. Now, I was thinking when I was putting this slide together, I wonder if that's why there's a recommendation as old as the hills really, about having a good night's sleep, because maybe some of it is for us to actually get all that lovely growth hormone overnight. I don't know, but certainly a growth hormone is up and down and it's secreted a lot whilst we're asleep. So I've given you a bit of a background on where growth hormone comes from and what normally happens with growth hormone in normal body systems. And now what I'd like to talk to you about is what happens to the body if there's too much growth hormone. Okay, so just to remind you, we've got those special cells in the anterior pituitary making growth hormone, and they're called somatotrophs. And what happens is, and as I say, pituitary tumours are very, very rarely a cancer. A tumour, I would say, when I'm just trying to describe this to a patient, is a collection of cells which has got a bit busy, maybe busy because it's grown, maybe busy because it's making too much hormone. And so this would be a pituitary tumour of these growth hormone secreting cells, the somatotrophs, and they're making too much growth hormone. So there's too much growth hormone in the bloodstream. Now, if this happens before puberty is finished, okay, so that's for argument's sake around 18, we call this gigantism. And if this happens after puberty, so as an adult, we call this acromegaly. And I thought it might be worth for a minute explaining to you the difference between those two things. I just had a quick look before I started speaking, and I think actually most of us on the call on this meeting are adults, but it might just be nice to describe the two things because I'll show you some pictures after that. So why does it make such a difference about when we see too much growth hormone as to what it's called? Why is it called two different things? So this is a picture of the wrist, okay? So I'm going to start on this side here where my cursor is. These are our finger bones. These are some of the wrist, some of the bones in our hands, and then these are our wrist bones, okay? And what you can see here is this is an adult wrist, and there's this little white stripe here, okay? And there's a helpful arrow saying closed growth plate, okay? And in contrast, this is a child's wrist. And you can see that actually they don't have a white line. They've got this gap here, and that's called a growth plate. So when we're growing from child to adult, as we get taller, for example, as our bones grow longer, they grow longer via these growth plates. So these growth plates have got special cells in them which are making new bone and increasing the growth. Now, as I say, once puberty is over, these growth plates fuse, they close, so you've got no gap anymore, just a white line, and so no further growth lengthwise is possible. So I know you can't see me, I'm sitting down, okay, but you have to take it from me. I'm actually a very small person, okay, I don't know, 5'1" probably. Even if I saw lots of growth hormone tomorrow, I would never grow any taller, okay, because my growth plates are closed, my femur won't grow in length, that's the big thigh bone, I'm not going to grow taller, okay. In a child, however, or a young adult before the end of puberty, they have got the ability for these growth plates to grow and lengthen the length of those bones and for them to grow taller. So if adults have too much growth hormone production, they have something called acromegaly, where soft tissue tends to get bigger, but actual long bones will not increase in length. Okay, so they won't get increased in height. But children and young adults before they finish puberty will get taller if they've got a tumor producing too much growth hormone. Okay, so as I mentioned, I'm going to focus really on acromegaly because I think the majority of us are adults, but very happy to take questions about this at the end. So acromegaly is a state of excess too much growth hormone. Okay, so after puberty. So you're not going to get taller with acromegaly, but things can change in terms of our skeleton. So if we have a look here where my cursor is on this side where we've got these black and white photos, these are taken from a publication that I find this such an enlightening set of photographs. So this is it's an American publication, and I think they have sort of work photographs where the same person is photographed regularly for the work kind of yearbook, for want of a better word. And I think the most important thing to highlight from these photographs is that acromegaly causes changes very, very slowly. So all of us look in the mirror usually every day and we see our face. And actually, um, it takes a long time to appreciate a change in our face because we're seeing the same face every day. So this is an individual with acromegaly. Here she is in 1977. And as you can see here by 1988, her facial appearance is quite different. And I imagine, I don't know the backstory of this patient, but maybe by this stage she'd presented with other clinical features, I don't know. But you can see that over time, in fact, things happen very slowly. And that's why often acromegaly takes a while to be diagnosed because I think often patients don't necessarily appreciate that something is changing because you're used to seeing your face every day in the mirror. But when you contrast this patient in 1988 compared to 1977, you can see some of the changes that we might see in the face of acromegaly. So as I say, soft tissue tends to get bigger. So she's got a change in the shape of her nose. She's got larger lips. If she popped her tongue out, she might have a bigger tongue as well. If you look to the side, she might have had an increased jaw. She might have actually, if she had a regular dentist, they might have picked up that her teeth, for example, might have had more gaps between them. That depends. And then the top picture here is this is a patient with acromegaly and this is a patient without. And you can see that the hands are much bigger. And it's not so much that the bones are bigger, but all that soft tissue around in the hands are bigger. And that's why patients with acromegaly can sometimes say that their wedding ring, for example, or another ring doesn't fit very well. Might say that their shoes have gone in bigger. And actually, in adults, we don't tend to have a change in shoe size. But I similarly think we can often argue things away, can't we, by saying, it's a different shop, or they come up big or whatever, come up small. So I can see how acromegaly often takes a while to be diagnosed, because as I say, it's a very sort of insidious, slow diagnosis often in terms of the changes that people see. Often patients, when acromegaly is quite active and the growth hormone levels are high, can complain of sweatiness and headache, and that certainly can be quite predominant symptoms as part of the sort of diagnostic workup that patients complain of those. Now, I've mentioned that acromegaly is due to a pituitary tumor, a benign tumor called an adenoma, making too much growth hormone. This is an MRI scan, and I suspect many of you will have had an MRI looking at your pituitary. This is called a sagittal section, which again is just, if you can see me, it's just down the middle. So it's taking a sort of picture down the middle of your brain, sort of between the eyes like that. This is a cross section of the pituitary gland, and as you can see, the pituitary gland is enlarged here. It shouldn't look like this, and the optic chiasm is stretched over the top. And I would like to talk to you about that, because I think some of you, if you've had a large pituitary adenoma, may have had some problems with your vision. So let's talk about that for a minute. So large pituitary tumors can certainly affect the vision, and that's important because I mentioned that the pituitary gland hangs from a stalk. At the top of it is something called the optic chiasm, which is where the nerve supply to the eyes joins and meets and then goes out again to the orbits, to the eyeballs, essentially. So I use this slide to teach medical students about what a pituitary tumor can do to vision. So this is me looking upwards at an empty lecture theatre where I teach the students. And this is me as an example of normal vision, where I can see the whole lecture theatre. If I'm standing at the front looking up, I can see the whole lecture theatre. The bottom slide shows what it would be like if I had a large pituitary tumor that was squashing my optic chiasm, squashing that nerve supply to the eyes. And what happens is I start to lose peripheral vision. So you can see here, I can't see the size of the lecture theatre at all. And what we tend to do if we're worried about there being a patient having a large pituitary tumor where it looks as if the optic chiasm is being compromised in any way, maybe being squashed or touched by the pituitary tumor, what we do is we send the patient to ophthalmology, that's the eye specialist, and we ask for something called visual fields, which some of you may have had done before, where you can press a button to say whether or not you see a light or not flashing. And I'm sorry, I'm just going to try and get that out of the way. So this is the left eye, and this is the right eye, and this is the patient who's had visual fields done. And as you can see, the black is what they can't see, and this side is what they can see. So this patient, consistent with seeing losing their peripheral vision here, can't see out of this eye to this side, can't see out of this eye on this side. So they can only see the things in the middle. And we call that a bitemporal hemianopia. Hemi is half, you've lost half of the visual field, and bitemporal because temporal is this outside part of it, is a temporal bone here and a temporal lobe. So that's why it's called bitemporal hemianopia. And again, you might have seen words like that on your clinic letters in the past or recently. Okay, so I'm going to just give you a little bit of a historical perspective on pituitary tumors making too much growth hormone. So now that I've explained the difference between too much growth hormone before puberty ends, which is called gigantism, and too much growth hormone after puberty ends, and those growth plates are fused, which is called acromegaly, I'm going to talk you through some historical and some just kind of sort of pop culture stuff, I think, for want of a better word, about people with too much growth hormone. So there is a suggestion I've read. I mean, goodness only knows, and we'll never know. There is a suggestion that, in fact, Goliath had a pituitary tumor making too much growth hormone. Now, he has to have had that before he finished puberty because he was a giant, so he got very tall and big. And then the suggestion is that David comes along with his catapult, and because Goliath has got his bitemporal hemianopia, he can't see out here. David very accurately gets his stone, and I'm afraid that was the end of Goliath. So goodness only knows that was a long time before any of us, but there is a suggestion that maybe Goliath had a pituitary tumor making too much growth hormone, so gigantism and a bitemporal hemianopia. This gentleman in the middle had gigantism. Again, this is the rest of his family members, so you can see how tall he is in relation to them. So again, he had a confirmed pituitary tumor making too much growth hormone in adolescence. And he is in the Guinness Book of World Records as the tallest man to have ever existed to date. And then this final gentleman is giving the lovely Roger Moore a bit of a hard time. And if you've seen any of those James Bond movies, his character is Jaws. And what I just wanted to show you is as he's trying to give Roger Moore a hard time, you might have a look at the compare and contrast the hand size. So this actor who played Jaws did have acromegaly. And if you look at his hand size here, and compare it to Roger Moore's, you'll agree that he's got quite big hands. And that again we see with acromegaly. So too much growth hormone in adults. Okay, so I showed you this graph here on this side a couple of slides ago, and I showed you that growth hormone is pulsatile, so it goes up and down. We make lots of it during sleep and a little bit in the morning to get us going with some other hormones too. As you can appreciate on this side of the diagram now, this shows you what happens in acromegaly. So that growth hormone producing pituitary tumor, so making too much growth hormone all day long. So you lose that pulsatility because all you have is growth hormone that's high all day long. And then, of course, you're going to get the body effects of seeing too much growth hormone. So I wanted to bring up about the diagnosis of acromegaly because, again, some of you will experience some of these tests, and I wanted to sort of see that they all made sense to you. So we can diagnose acromegaly with a high IGF-1 in the context of having symptoms and signs which are consistent with acromegaly. Many people still do what's called an oral glucose tolerance test, which is a sugary drink. And the reason that we do this and we don't just measure a growth hormone as a one-off is, as I've talked to you about, growth hormone goes up and down. It's a spiky hormone. So measuring a random growth hormone in clinic is not really going to be very helpful because if it's high, is it because it's at the top of a spike? Is it low because it's at the bottom of a spike? Who knows? So we have to do something a little bit more complex than that. So an oral glucose tolerance test involves you having a sugary drink with a certain amount of glucose in it, 75 grams. It can be all different. Some people use Lucozade, you can use all different things. And you take that sugary drink test and then you have a series of blood tests over a period of time. So normally when you have this glucose load, this sugary drink, growth hormone should fall. And that's what you see here in this person, that when they have a sugary drink, if they're a normal person, growth hormone should fall. If you've got acromegaly, so you're making too much growth hormone, in fact, when you have your sugary drink, growth hormone goes up, and we call that a paradoxical rise. A paradox because it's what shouldn't happen. It goes in the opposite direction to what you'd expect. So we see a rise in growth hormone when we have a sugary drink. And once we've confirmed acromegaly with a high IGF-1, obviously with a careful history examination with a high IGF-1, plus or minus an oral glucose tolerance test, we then do a pituitary MRI to look for a pituitary tumor. And I think in fairness, because for the most part, as I've mentioned, this is quite an insidious diagnosis because these changes in ring size and facial appearance can be quite slow and quite subtle. Usually you can see a clear pituitary adenoma there by the time the patient is presenting with these symptoms, and you can see something on MRI. So one of the questions might be, why do we need to treat acromegaly at all? Because some people might say, well, why do I need this treatment? Yes, my ring size has changed, but I don't really notice anything else. So I mentioned a few slides back that too much growth hormone makes things grow, and it also has what I call, or anyone calls, metabolic effects. And what that really means is that it increases blood pressure, it increases blood sugar, and that's not actually good for us over a period of time. It's not great to have high blood pressure, and it's not great to have high sugar particularly if that ends up being type 2 diabetes, for example. And when we have this combination of high blood pressure and high blood sugar, we call that increased cardiovascular risk, which is just really a term for saying cardiovascular risk is about how to keep our blood vessels healthy, particularly the blood vessels that supply our heart and our brain. So if we don't treat acromegaly and we've got somebody then who's going to be likely to develop high blood pressure and high blood sugar because their acromegaly is not under control and their growth hormone levels are very high, that wouldn't be very good for keeping their heart and brain healthy. So that's really fundamentally why we treat acromegaly. We want to make the patient's heart and brain as healthy as possible in the long term and reduce that cardiovascular risk. Okay, so the first line, so in other words, the treatment that we would like to do first and foremost for acromegaly is surgery. And for the majority of patients, we do something called transsphenoidal pituitary surgery, and I'll explain why it's called that. In the old days, before this was available, before my time, in fairness, patients would have had what's called a craniotomy, where the skull would have had an operation. You would have had the skull opened up, which is obviously quite a big operation. So actually, our surgeons being able to do transsphenoidal pituitary surgery is tremendous because that's a real change actually for patients. It's a lot less I think stressful for patients. You know that there's not the sort of it's not sort of drilling through the skull front of the skull in the same way. The recovery is much quicker. So this is a real positive for patients. So transsphenoidal surgery, trans means across, sphenoidal is the sphenoid sinus. So let me explain why it's called transsphenoidal pituitary surgery. So the first thing is the surgeon goes up the nose. Okay, so this is going up the nose of this patient. Okay, so the first thing that they get to is this bone here. And as you can see, there's a sort of bony cave here, and it's called the sphenoid sinus. So the surgeon drills into that, okay, keeps pushing across then because it's just air, and then drills through this bone here. And you can see, lo and behold, the surgeon is then in the pituitary fossa. This fossa is the little dip that the pituitary sits in, and can take away the pituitary tumor, pull it out through the nose, and there we are. We've had a removal of the pituitary tumor without having to open the skull bone at all. We've gone in through the skull base effectively. This is the bottom of the skull. So an access through the nose, which is tremendous. Now, the purpose of surgery for acromegaly, or any treatment for acromegaly in fairness, is to try and normalize that growth hormone and IGF-1, because I mentioned to you that both of those are affecting growth and other metabolic effects in the body. So if we're going to treat acromegaly, we want to try and make growth hormone and IGF-1 normal. IGF-1 usually takes about 3 months at least to normalize after an operation, so we can't interpret that immediately, but we try and monitor that over time after an operation, and we're looking for those to be normal. Now, some people who have acromegaly may have medical treatment before surgery to try and make the tumor a bit smaller. That's not uncommon. We can do that usually with a drug called a somatostatin analog. So somatostatin is made in the body by the hypothalamus, which sits just above the pituitary gland, and that switches off growth hormone production. And very cleverly, there are now these drugs which are injections which mimic somatostatin and also switch off growth hormone. Or they're called octreotide or lanreotide. They're usually given every month, and they can actually shrink the acromegaly causing the growth hormone secreting tumor and lower the growth hormone and IGF-1. So they're quite handy to use before an operation to try and shrink the tumor and to try and control the growth hormone, particularly, for example, if patients got headache, not feeling very well with headache and sweatiness, trying to lower those growth hormone and IGF-1 levels before an operation. Some pituitary tumors making too much growth hormone can also express a dopamine receptor. And I've put that here because some of you may recognize this name. If you're a prolactinoma patient, you may recognize this name because cabergoline is a drug which binds to D2 receptors on the pituitary and reduces prolactin, but also can reduce growth hormone secretion too. So sometimes dopamine agonists can be used, they're tablets rather than injections, to try and lower growth hormone and IGF-1 before an operation. But generally speaking, unless there's reasons why someone, for example, can't have a general anesthetic, our preferred treatment of choice would be surgery. Now, sometimes patients have radiotherapy. usually after surgery, if, for example, not all of the tumor is possible, it's not possible for all the tumor to be removed. Radiotherapy is like a deep X-ray treatment. It's looked after by what's called an oncologist. They are a cancer specialist. It's not to say that it's a cancer, but they're obviously expert in this as a treatment for some types of cancer. So radiotherapy is done by oncologists. It's very slow to work usually. So if it is going to be a treatment for acromegaly, we after surgery, for example, we end up usually asking the patients to use some medical treatment too for a few years before we move on to for the radiotherapy to work. Sometimes after surgery, if we're not able to remove all of the growth hormone producing tumor, patients might end up having medical treatment to try and control their acromegaly, so to try and bring that growth hormone and IGF-1 into the normal range. And that could be, as I say, after an operation, patients might continue octreotide or lanreotide, for example. So my final bit of the talk is to talk about the consequences of growth hormone being low in the body. So we've talked a lot about what happens if it's too high, what happens if it's too low. So usually that's going to happen because of a pituitary tumor problem. So either the tumor, a pituitary tumor has damaged the pituitary gland and it can't make growth hormone anymore. Maybe because of surgery to the pituitary tumor, you can't make growth hormone anymore. Sometimes if you've had radiotherapy to the pituitary gland, you can't make growth hormone anymore. And there are other reasons. You can have different pathologies of the pituitary, such as inflammation. You might have had a bleed in the pituitary. All of those can cause pituitary damage and therefore growth hormone secretion not to happen effectively anymore. So the first thing just to say is that growth hormone replacement is an injection. And obviously, if you're somebody that doesn't like injections, and lots of people are like this, then you have to think whether growth hormone replacement is for you or not. And just to explain why it has to be an injection, growth hormone is a protein hormone, like many hormones. Not all hormones are made from protein, but growth hormone is. And so if we were to have a growth hormone tablet, it would be broken down instantly in our tummies because our tummies have got acid in them and enzymes that break down all different parts of our food. But they're very good at breaking down protein. So we can't give a tablet of growth hormone. We have to give an injection. So in other words, to bypass our tummy and our gut. And so this sort of daily injection, and there are moves potentially for longer acting weekly forms of growth hormone, but for the time being for adults, it's a daily injection. Some patients with growth hormone deficiency choose not to have growth hormone replacement, which is absolutely fine. That's their prerogative because they don't really fancy a once daily injection. Now, some people, unfortunately, take growth hormone for the wrong reasons. So there was a news report, I can't remember the date now, this is a little while ago actually, that Sylvester Stallone had been making a film in Australia. I am conscious that this is going to be on YouTube, but this was all in the papers. I didn't get anything from anywhere else. It's all in the Guardian, I think. He had been found guilty of importing growth hormone into Australia, and I think that's because, and you can see this other picture that people are trying to sometimes take growth hormone to build muscle. So sometimes people do take growth hormone for the wrong reasons. They might take too much of it trying to build muscle strength. So it can be a drug of abuse. I'm just telling you, a bit like you might have heard about that for testosterone, for example, too. Sometimes people take it for the wrong reasons to try and become more muscly. So let's just run through for a minute the reported benefits of growth hormone treatment in patients who are not making enough growth hormone. So growth hormone treatment, so replacement, if you are not making enough growth hormone of your own, can increase lean muscle mass, which actually means skeletal muscle, which is good. Skeletal muscle is what makes us run around and walk around. It can reduce fat mass by approximately 3 kilograms, just to put it in perspective about how much fat mass reduction there is. It can have variable effects on cholesterol, so it can be reported to improve lipid profile. However, just to remind you that there are also a group of tablets called statins, which lower cholesterol, and it's not actually clear, in fairness, if growth hormone replacement is better than a statin at reducing cholesterol. So I'm just saying there are alternatives to reducing cholesterol. It doesn't have to be growth hormone. Growth hormone replacement may improve bone health. So it increases bone mineral density, which is how strong our bones are. We can look at that via something called a DEXA scan, but it's not actually clear, in fairness, if it actually reduces fracture risk. So it definitely improves bone strength, but we're interested in also if it reduces fracture risk, and that's less clear. And then there's lots of papers out there looking at something called quality of life. And this is a tough one because this has been shown to be reduced in patients with growth hormone deficiency. That doesn't mean that every patient who has growth hormone deficiency has a bad quality of life, but it's just that it has been shown to be reduced in patients with growth hormone deficiency. And I think it's really difficult to try and work out quality of life because it's going to be a questionnaire. All of us know that we have good days and bad days. And actually, what the questionnaire is on a good day or a bad day, it's a very difficult thing, I think, to tease out from using any tool, really. And it's been quite difficult to show improvement of quality of life with growth hormone treatment. But we luckily have got nice guidelines that give us a framework for growth hormone replacement. And so as I say, having those guidelines means it's very clear what we can do around growth hormone deficiency. So if you're a patient where there's been a concern, you've had a pituitary condition about whether or not you've got growth hormone deficiency or not, so you're not making enough growth hormone, you'll have to have a special test with various time points to see to confirm have you got severe growth hormone deficiency. So there's quite a strict cutoff about what that is. And the reason I've put a complex test here, a fancy test, is because this won't be a single growth hormone blood test. As I've mentioned, growth hormone is quite complex with it going up and down, etc. So if we're trying to sort of see how much growth hormone you can make, we need to do a fancier test, which often requires a sort of day admission with lots of blood tests around it to try and work out if you're really making enough growth hormone or not. We would then ask the patient to fill in a quality of life questionnaire, which, as I say, gives us a score as to what the quality of life is like. As I've mentioned to you, for the time being, in adults, growth hormone will be replaced as a daily injection. So you have to be up for that. There's not a tablet form. And then if you were to start growth hormone replacement for growth hormone deficiency, you would measure the response by improvement of quality of life. So we'd look at that AGTA score, that questionnaire score over time, and we'd also look at the change in plasma IGF-1 levels. So coming back to remembering, IGF-1 is made from the liver in response to growth hormone. So that's our marker. It goes up very, very high in acromegaly, but it goes up if we treat someone with growth hormone deficiency. So we can use it as a marker of how successful the treatment is. So I'm just going to finish with these couple of slides from what's called a consensus statement. So a consensus statement is where you get a group of experts who come together from, usually this consensus statement was actually from all different countries. I don't know if any of you listening are from Manchester. There's a wonderful endocrinologist in Manchester at the Christie called Claire Hyam, who's a colleague and friend of mine, and she was on this consensus statement. So it was looking at experts in the field, and the question really that these experts needed to answer was around the safety of growth hormone replacement in patients with tumours. Okay, so starting with patients with pituitary tumours, as I've mentioned, just to reassure you, not a cancer, okay, but certainly something that there'll be a concern. Could it grow? Because we've heard about growth hormone making things grow. If you are a patient with a pituitary tumour receiving growth hormone replacement, should you be worried that it's going to grow with growth hormone replacement? And this consensus statement is very clear that there is no evidence that pituitary tumours grow with growth hormone replacement. So you do not need any different monitoring to the next person with a pituitary problem who's not receiving growth hormone replacement. So there isn't any evidence that you're going to do yourself harm with a growth of your pituitary tumour if you receive growth hormone replacement. If you had a pituitary tumour, say you had an operation to remove that pituitary tumour, and maybe on serial follow-up MRIs, it showed that that was growing and you were receiving growth hormone replacement. The consensus statement is quite clear, and I think this was very fair clinically. I think this is what I would do too. I think that then requires a discussion with the patient. Would you stop the growth hormone? Sort out what everyone was going to do about the pituitary tumour, think about restarting at a later date once you've had your next set of treatment. But that's very much a discussion with the patient and the medical team about the risks and benefits in terms of, how you might feel on and off growth hormone, about what type of tumour it is, all sorts of things. So it's definitely a discussion point. Doesn't mean you have to stop it automatically, but it would certainly be a discussion point with the patient if you were on growth hormone replacement and your pituitary tumour was growing back. Doesn't mean that the growth hormone replacement has caused that, but it's just something to have a discussion about. Then the second bit of the consensus statement, which was also really helpful, was about cancer. So this time we are talking about tumours that are malignant, because some people might have had a pituitary condition, might have had growth hormone deficiency and have growth hormone replacement for that, but might also be a cancer survivor. So might want to know more about, is this growth hormone replacement going to do bad things for their future cancer risk? So to start with, the first point here is to remind you that if you're an adult patient with growth hormone deficiency, so you've had a pituitary condition that's caused growth hormone deficiency, replacing that growth hormone does not increase your cancer risk. So you aren't going to do anything bad in terms of your increased cancer risk if you choose to have growth hormone replacement. And I think that's enormously reassuring. In terms of if you're a patient with a pituitary condition who has been treated with growth hormone replacement because you're deficient in growth hormone, and then, for example, you're diagnosed with a cancer and you're having active cancer treatment, the recommendation is not to have growth hormone replacement. Now, I think in fairness, I appreciate I've just spent a while explaining that there isn't a risk that we can see in any of the evidence that we have that growth hormone replacement increases growth of cancers. In fairness, I think, and I'm not a cancer specialist, don't forget, but I think in fairness, when you have a cancer, people want to see, or your medical team wants to see, that the treatment's been effective and monitor you over time. So I think what you want to do is make it as clean as possible and not have anything else in the mix which could be muddying the waters in terms of growth of anything. So I think in fairness, if you've got something that can cause growth of cells, then I think if you've got a cancer that's being treated, it's not unreasonable to stop your growth hormone replacement. Now, if you've come through your cancer treatment, okay, and you're a cancer survivor, so your tumor, your cancer is what's called in remission, it's all sorted out. There's no evidence that having growth hormone replacement, if you've got growth hormone deficiency from a pituitary problem, is going to make your cancer come back. But clearly, that would be a nice open conversation with your cancer team, with your endocrinologist, about the risks and benefits of growth hormone treatment. So I hope that's all clear in terms of cancer. So just to summarize, because we obviously need to leave time for questions and answers, this evening I've told you about acromegaly, too much growth hormone in adults, and I've told you that it increases what's called cardiovascular risk, so we need to treat this to protect hearts and brains particularly. I've told you that the first line treatment for acromegaly is surgery, but there are other options. And then we've just explored the concept of too little growth hormone, which we can treat with once daily injections. That's going to be in a group of patients who've had a problem with their pituitary in the past. And patients can discuss this with their endocrinology treating team about the pros and cons, the advantages